Good morning and welcome to the first session of the EOC Showcase 2014. Jigisha and I would like to share our presentation titled More Than Skin Deep, Linking EOC into the Concord Burns Unit. Before we commence the EOC part of the presentation, I'll just briefly tell you a little bit about Concord Hospital. It was built post-World War II for veterans returning from war. As you can imagine, plastic surgery and reconstructive surgery was very much part of the treatment for returned soldiers. So with that gained experience, burn survivors were then able to be treated. So a burns unit was established and a lone burns unit was established in the 80s. The current burns unit is located here on the 7th floor of this obviously updated sort of building. The actual burns unit has an inpatient facility, an ambulatory care facility with several bathrooms, specialised bathrooms. It also has an operating room suite which includes the induction bay, the operating room and a recovery room. Has a skin laboratory as well. We have 10 allocated inpatient beds, but we have the capacity to increase to 16. Because of the surgical expertise, sorry, now I've got a bit lost. Now just to introduce to EOC, we commenced EOC in 2010. We have 2 internal coordinators, or facilitators I should say, Jigisha and I, and 2 external facilitators, Leo Turner and Carolyn Wildball. We have EOC coordinators as well, which help us get through our to help us through EOC. Firstly, for the preparation phase, counselling and debriefing was important. The actual team needed to be able to talk, and our external facilitators were terrific at that. We then moved on to quick fixes and our values. Quick fixes were really important. They were affordable, very affordable and able to be done quickly. So we've got 3 examples here. The change room facilities were upgraded. Just a few shelves and that sort of thing was required. The bathroom key was changed to a keypad, so no more lost key. Simple signs were provided for when we were interviewing patients or when we were in a dressing procedure. Again, these were very small changes, but it really introduced EOC. It really established a trust, engaged people and empowered them. Next to our values, we wanted to understand who we were and where we were going. We decided to create an acrostic poem. It was titled CRGH, as in Concord Repatriation General Hospital, Burns Nurses. And we chose descriptive words that were going to reflect on what we were. This poster was then enlarged and displayed in our burns unit as well as our ambulatory care clinic. It made us feel very proud and we had an identity, so that was really, really important. Then we moved on to the assessment stage. Observations included dressing procedures, the busyness in ambulatory care, and then we moved on to workforce data, which included staff satisfaction, patient and carer stories, very, very important, and then audits as well, including excess skin, donor site skin, which Jigisha will talk in a moment. But firstly, I wanted just to briefly talk to you about observations and patient care stories. One observation was in our clinical handover. Our external facilitators came in and observed several sessions of clinical handover. Firstly, it was done in the tea room, which of course was where everyone came to have lunch, to relax, to watch TV, to look, just to relax. So of course participation was reduced and the focus wasn't there. There were several interruptions. ISPA was not followed and it was a lengthy sort of procedure. So what are we going to do? How are we going to change that? We needed to change that culture. So our action plan was to create a short film. Out of the observations, we picked out quotes and wrote a script. The nurses then actually acted and we filmed it, and then that film was uploaded to the computer and we all watched it. So that obviously created discussion, concerns, questions, but it raised awareness of our current handover culture. So the staff really felt that they were ready for a change and they needed a change. So walk around handover has now commenced in 2014 using the ISPA rules. Now, for patient stories, really, really important and very empowering. We interviewed 10 inpatients and 10 outpatients, and then we've gone back and also interviewed several more since then. We divided the patient stories into positive and negative and looked at themes as well. The positive quotes were great and they needed to be celebrated, so we put them all the quotes up onto large pieces of cardboard, put them into the unit, both in ambulatory care and in inpatients, and put them up for International Nurses Day. Some examples of these quotes are, best day in any hospital I've ever had, really good mob, thank God for the nurse who gave me my enema. They treat me like a person, compassionate, knowledgeable care. And the last one, the nurses offered pain relief more than you need. I've put this quote in purposely because not everyone unfortunately was able to have adequate pain relief. And this is because some of the stories came back where obviously pain was a big issue and maybe we weren't addressing every patient's needs. So unfortunately there are negative quotes, but I think it's more importantly that we recognise that and make change. For example, one person that had their burn debrided, she said, the pain was excessive and that night I required endone. I could not sleep. Another person, when she was getting a special dressing applied to her burn, the pain did my head in. Another person, when the dressing was applied to my face, it felt like sandpaper, gave me so much pain. And then lastly, it was the most painful experience. So these are a few quotes. So obviously this was a problem, so we needed an action plan. We displayed their stories and discreetly in folders and also displayed them in discrete areas as well. This obviously created a lot of discussion which was analysed, and we realised that some patients weren't getting enough analgesia, patients weren't getting the right analgesia. So we have gone back and anecdotally, patients have less pain now, but we need to go back and still continue our patient stories. Now to the audit, which is titled Excess Autologous Skin from Donor Sites. This is one of the audits that we did, and I'm going to ask Jigisha now to take over to this part of the presentation.
Thanks, Sue. Morning, everybody. My name's Jigisha, and before we actually go into the rest of the presentation, just wanted to say that some of the photos are quite confronting. We have obtained patient consent, obviously, to use these photos in the presentation. And also, before we actually talk about the audit, it's important to understand the actual surgical process that's involved during burn surgery. So a full thickness burn is when all the layers of your skin are burnt, and it actually requires a surgical debridement and a split thickness skin graft to close the wound. The skin is actually harvested from what we call a donor site. The donor site is taken from an area adjacent to the burn or from the other limb, for example, as you'll see in a couple of photos. So with this patient, this photos demonstrate the surgical process. So in the top photo, we're just harvesting the donor site. The donor site is harvested obviously using a special surgical equipment. It is a 1/10 to a 2/10 of a millimetre thin. This is what a donor site looks like once it's been harvested. And then we mesh the skin. So we put the skin that we've taken from the patient through a special skin mesher. We make it 2 times, 4 times bigger, depending on the type, on the size of the wound that we need to cover and how much skin we're going to take for the patient. Unfortunately, there is no studies to say that this percentage of burn requires that much skin to be harvested. So this is the same patient that we saw the photo of before. So we've debrided the burn wound, we've taken all the burn tissue off, and we've laid the skin graft on. This is 6 months post-surgery. Obviously, burn injuries do scar. As you can see, that's the scar from the burn. But also, I'm not sure if the photo actually depicts, but on the other limb, on the left-hand side, is where the donor site is. There's faint scarring and pigmentation after 6 months after surgery. We do take skin, as I said, and if the skin that we've harvested, if there's excessive skin that's stored, we actually store it in a special skin storage medium. The reason we do this is so that we can actually use the skin if there's graft failure. It has to be used within 7 days because it actually loses its cell viability and there's an increased rate of bacterial and fungal contamination after 7 days. The skin is stored in special refrigerated conditions between 5 to 7 degrees and is discarded 7 days after being harvested after surgery. The problem with donor sites are obviously they're extremely painful. Some patients actually can say that the donor sites are more painful than the actual surgical site. They also, as you can see, scars with some patients more than others. Patients with white skin type, fairer skin actually have less scarring as compared to patients with a darker skin tone. They're also a wound that we're trying to heal. They can also cause infections. This is a photo of a young boy who is of a darker skin background, as you can see, and that was the donor site that was harvested after surgery. And the photo is when it's healed 10 days later. Now, this patient actually did have a lot of pigmentation problems and itchiness and scarring issues. So we realized that obviously we are taking the skin because we do need to take the skin to cover the wound, but we are storing a lot of skin and it's being discarded. This raised a lot of conversation about why are we doing this? Why are we taking more skin than we require? Yes, there is no rule as to how much skin we can take, but is there a way we can try and measure the amount of skin that we're storing and discarding to probably try and make this process a little bit more effective so it's more comfortable for our patients? We're trying to heal the wound, but we're creating sometimes a wound that is a lot bigger than what it might be required. So we decided to audit the amount of skin that was being stored and discarded. The way we did this audit was, as I said before, we store the skin in the special skin storage medium. So we decided to weigh the empty pot with the medium in it and using the special lab scales that we have in our skin laboratory. And we recorded this weight on top of the lid of the skin storage medium. Once we actually stored the skin, before we discarded after 7 days, we used to weigh the skin again. And the difference in the weight, the pre and the post, was actually the weight of skin that was being discarded. We did 2 audits, a preliminary and a successive audit. This is just a graph showing you the results. The next slide actually gives you more numbers. And in the audit, what we did was we took 17 patients. The preliminary audit was done over 10 weeks. And in those 10 weeks, we realized that we discarded 136 grams of skin for those 17 patients. And it ranged between 1 to 55 grams. And the average, we use it approximately calculated to what we say 4% total body surface area. We calculate, one of the ways of calculating the percentage of a burn or of a wound is by using what we call a Palmer rule. Palmer rule is the palm of an average person equals to 1% of total body surface area in that person. So the 55 grams of skin that we had, say, for one patient, calculated to be approximately 4% total body surface area for that patient. The average weight of skin that was being discarded per patient was calculated to be approximately 4.58% total body surface area. Now, these results were communicated back to the surgical team and the perioperative nursing team, and we did a successive audit of 17 patients again, and this was done over 14 weeks. And we realized that we've actually discarded 60.5 grams of skin after the first audit, and the average weight of skin discarded per patient was reduced to 0.259% total body surface area. So we noted a decrease in this amount of skin that we were discarding by almost 50%. So the outcome was, obviously, we were storing and discarding less skin, which was obviously beneficial to our patients. This reduced the size of donor sites. There was also a change in culture when the surgical planning process. More planning about the donor site size and location. We were also promoting patient participation. We were asking the patients a lot more, where would you like your donor sites to be taken? It makes a lot of difference sometimes taking just an inch over your knee, whether you can wear shorts or not, so we just had to involve the patients a lot more about where we were taking the donor sites from. Improved communication between the surgeons and the team in the operating theatre regarding the size and the donor site. So the surgeons were getting a lot more on board with this audit that we were doing as well, and the participation of patients. change in practice, limiting the initial harvesting of donor sites. So if we have a patient who comes in with a large burn injury, instead of going and harvesting all the donor sites before, we used to actually go back to see if we needed more skin. So take some donor site, use it, and go back to the patient to harvest more donor skin if required. And so that was our audit that we did. We're going to continue doing the audit to see if we actually continue to see if we're actually discarding less skin. And I'm just going to pass it over to Sue now to conclude the presentation. Thank you.
Sure. So from here, as Jigisha said, we're going to evaluate the walk-around handover, continue with our interviewing our patients, collect some more staff satisfaction, continue to monitor excess autologous donor site skin. In conclusion, we believe that EOC is more than skin deep. It has made us more observant, given our patient a voice, empowered our teams, changed cultures and improved the care we deliver. This photo is of our multidisciplinary team, and as we progress deeper into EOC, we engage with more of the team members to evaluate the care we deliver. Thank you.